Hello, everybody. Thank you so much for being here today. My name is Deb Pollock, and I will be helping moderate today's session on predictors of disease progression, biomarkers, and treatment response in children with Dr. Marva Moxey-Mims. It is my honor to introduce our speaker today. Dr. Moxey-Mims is Chief of Division of Nephrology at Children's National Hospital, Washington, D.C., ranked in the top 10 pediatric nephrology programs in the United States. She was previously at the National Institute of Diabetes and Digestive and Kidney Diseases at the National Institutes of Health in Bethesda, Maryland. There she served as Deputy Director for Clinical Science in the Division of Kidney Urology and Hematologic Diseases, overseeing a portfolio of research, including trials for kidney disease in adults and children, and the director of the Pediatric Nephrology Program. Dr. Moxey-Mims focuses in children's clinical research to improve the care of children with kidney disease and as a tool to educate trainees. She has over 135 scientific publications, including journal articles and book chapters. She is board certified in pediatrics and pediatric nephrology and is a member of several national boards and committees. Dr. Moxey-Mims will be able to take your questions at the end of the session. So feel free to type your questions in the Q&A or the Zoom toolbar anytime. We should have plenty of time at the end to answer them. With that, I turn it over to you, Dr. Moxey-Mims. Thank you so much for being here.
Thank you to the meeting organizers for inviting me. It's an honor to speak to this group. I've been a huge fan, for lack of a better word, of NephCure and the work they do since my time at the NIH. So I'm going to go ahead and plunge in as we're going to speak about, as you see here, predictors of glomerular disease progression, looking at biomarkers and treatment response in children. And I thought we would start first with defining biomarker. So biomarker is a characteristic that's measured as an indicator of normal biological processes, or what we know as health, pathogenic processes or disease, or they can be looking at responses to an exposure or an intervention. So an exposure meaning, for example, if you were exposed to some type of toxin, is there a way that you can test for something that will confirm that that's what you were exposed to, or an intervention, a treatment, looking at how you respond to treatment? Are there specific things that we can look at and measure that will tell us how you're responding to a treatment? So why do we need biomarkers? Glomerular disease, as most of you know, can present in a variety of ways. There's no one way that a particular disease presents. And so it makes it very difficult to tell, is this disease A, is this disease B? So biomarkers will help us to differentiate disease types. There are some biomarkers that can predict clinical outcomes. And I'll get into this a little bit later, but for example, if you have a kidney biopsy and it shows a lot of scarring in particular parts of the kidney, there are scoring systems that will say if there's this much scarring or this many inflammatory cells that are in there, the prediction is that this patient will do well or this patient will not do well and progress to chronic kidney disease. And some biomarkers can guide treatment. As I mentioned before, if you have a marker that can tell you, yes, this person has responded to treatment, you can then use that in new patients and track that as a way of determining whether treatment has made a difference for that patient. So there are different types of biomarkers based on what I just mentioned. Diagnostic, ones that will tell us precisely what the diagnosis is that the patient has. And then prognostic markers are the ones that tell us what the outcome is likely to be based on the disease when the patient first shows up in the doctor's office. And so these type of biomarkers are checked in people who have not yet been treated. As opposed to predictive biomarkers, they provide information on whether or not the treatment that you're given will have an effect. And so it can tell us about the severity of disease and the likelihood of a given treatment having some benefit. So it can help you identify who responds and who does not respond to a particular therapy. Biomarkers are also divided into two groups of candidate or validated. A candidate biomarker, you can think of it as one that somebody has discovered in their research, and the light bulb goes off that, hey, this seems to show up in patients who have disease X. So it's identified an initial group of patients. And then when you try to validate it, you take that and now you go to a new group of patients and run that test and see, does it actually work in this new group of patients to tell us what it is we're looking for? And once you have that, it's called a validated biomarker. And the FDA, for example, has very specific criteria that they use to validate a biomarker that you can use, or that drug companies can use for endpoints, the drug for which they're trying to get approval. So what's the ideal biomarker? Biomarkers should ideally be reproducible, meaning it's not a fluke that you found it in this one patient with disease X or a few patients with disease X, but then in other patients who have that same disease, you can't find the biomarker. They should have high sensitivity and high specificity, and I'm going to define those on my next slide. Ideally, they should be non-invasive, meaning something that you can do. A urine test, I consider blood tests to be pretty non-invasive as well, meaning you don't have to physically go into the patient's body like a biopsy, for example. You would want rapid results, and hopefully you would want it to be inexpensive in order for it to be particularly useful. So I wanted to define sensitivity and specificity. I'm sure you've heard those terms thrown around on the news and everything else when they talk about tests for cancer, tests for various diseases. So sensitivity is the ability of a test to correctly identify patients with disease. So you know that this patient has this disease, and when you do this test, it says this patient has this disease. If the test says a patient has a disease and they in fact do not, that's called a false positive. So sensitivity means true positives. Specificity is the ability of a test to correctly identify people without the disease. So this person doesn't have the disease, you run the test and it says, no, they do not have the disease. So true negatives. The corollary to what I said about sensitivity, if the patient actually has the disease and the test says that they don't, that's a false negative. Now, there's no test that has perfect sensitivity and perfect specificity, but you would like those to be high. 50% doesn't help you. That's the same as a coin toss. If the sensitivity is 50% or the specificity is 50%. So you want high sensitivity and specificity, ideally, in the 90% range. So what are some of the traditional surrogates or surrogate biomarkers that we use currently? For the diseases that NephCure focuses on, one of the big traditional surrogates we use is proteinuria. We know that the nephrotic syndrome, whether it's from minimal change disease or FSGS, or you have membranous nephropathy, all of those diseases present with proteinuria of varying degrees. And there's some data out there that would indicate that your level of proteinuria, how high that proteinuria is, can be a prognostic marker, but that's not an absolute. I've certainly seen kids who present with huge proteinuria values and they still respond to treatment and still do well. The serum creatinine, which is a marker of kidney function, is of course another one of the traditional markers that we look at, and that tells us what the patient's kidney function is at that moment. So it's not giving you information about down the road, although again, there are some data that say if somebody presents and their serum creatinine is already high, meaning their kidney function isn't good, that can also be a predictor of not so good outcomes down the road. The estimated glomerular filtration rate is another way of assessing kidney function. Most formulae use the serum creatinine with or without other markers, and you plug them into a mathematical formula and it estimates what the patient's kidney function is at that time. And again, if that number comes back low, meaning poor kidney function, that can be predictive of poor outcomes in the future. The urinalysis itself, when we look at the urine under the microscope and look to see how quote unquote active the sediment is, are there lots of red blood cells? Are there lots of casts? What are we seeing in the urine that's making us particularly worried about this patient? So I'm going to just give a very brief case study to make the point about why biomarkers are helpful. So if I have an 8-year-old who comes into my clinic, he's swollen, we check his urine, he's got very high levels of protein. We do blood tests, his serum albumin is low, his lipids are high, and we do a variety of other blood tests and shows that he has no other underlying disease that could explain this. And so we diagnose him with idiopathic nephrotic syndrome. And idiopathic just is the medical term for, we don't know why. It's there, but we don't have a defined cause for this. Our standard treatment in this situation is to start high dose oral daily corticosteroids, usually 2 milligrams per kilogram, no more than 60 milligrams per day. And we see, does the patient respond? And we usually look for a response sometime in the 4 to 6 week range. And then if he doesn't respond, he might undergo a kidney biopsy or have his medication changed or both. But wouldn't it be wonderful to have a biomarker that we can use right at the start that will tell us, is this patient likely to respond to corticosteroids, or should we be looking in a different direction? So let's talk a bit about idiopathic nephrotic syndrome. It is the most common type of pediatric nephrotic syndrome, and we often classify it by response to corticosteroids, so steroid responsive, steroid resistant. We can also classify it by biopsy findings. So the majority of children in this age group who present with nephrotic syndrome will have either minimal change disease or focal segmental glomerular sclerosis, FSGS for short. So here is how we define the steroid responsiveness states. The patient can be steroid sensitive, meaning they respond to daily high dose oral steroid, or they can be steroid resistant, which means that they don't respond. You put them on the medicine, nothing changes. And then the group of steroid sensitive patients can be further subcategorized. There are patients who have what we call frequently relapsing nephrotic syndrome, and that is that they have 2 or more relapses, and a relapse being you've responded to treatment, but now you're back having all the signs of nephrotic syndrome again. So the frequent relapses have 2 relapses within 6 months, or 4 or more relapses within a 12-month period. Then there are the steroid-dependent patients. They are the patients who relapse while you're trying to decrease the steroids, taper the steroid dose, or within a short window after you've stopped the steroids, usually defined as within 2 weeks of stopping steroids. So I wanted to share this with you just so there's an understanding of what we mean when we say minimal change disease. So I know most of you would not have seen what a kidney biopsy looks like, but take my word for it, this is a normal, a normal biopsy. There are what we call capillary loops around these areas, and I will come back to that. So this is where the blood flows through the kidney. This is the glomerulus. And this would be consistent with minimal change disease, which looks completely normal on what we call light microscopy. There are abnormalities that you would find on electron microscopy, where you just have to look at a much higher magnification to see if there's anything wrong. Focal segmental glomerular sclerosis, on the other hand, I think you can see here all of this material that's clumped, and the capillaries are closed as compared to looking at these capillaries that are open. And this is what focal segmental glomerular sclerosis looks like. The thing about focal segmental glomerular sclerosis is that it's really just a descriptive term for what we see. There are lots of different diseases that can cause focal segmental glomerular sclerosis. And focal, meaning that it's just in certain parts of the kidney. Segmental, as you see here, meaning it's only in part of the glomerulus, not the entire glomerulus. And sclerosis is just a term that means scarring. So based on the case study that I gave you and those descriptions I gave you, this patient, he'll get corticosteroids and he could go either way. We don't know. Is he going to be resistant? Is he going to be steroid sensitive? And if he is steroid sensitive, is he going to be one of these kids that frequently relapses, or someone that you can never get him off steroid? And of course, we know the downside of somebody being on corticosteroid for extended periods of time. It impacts their growth, can lead to diabetes. For some kids, it impacts their behavior. So just the overall pattern of not wanting to be on high dose daily steroids for years at a time. So there are a series of what we call candidate biomarkers. As I mentioned, that means biomarkers that some people have found either in small patient studies or in animal studies, animal models of nephrotic syndrome that show that they may have some promise. I'm not going to go through each of these, but you can see the list here. The problem is that none of these have been consistent to date. They've all, caused excitement in the community when they were first identified, but then when you try to look in bigger studies, it's difficult to actually validate them. One of the ones that caused really a lot of excitement when it was first identified years ago was SUPAR, that you may have heard about, which was initially thought to be a good marker to differentiate between minimal change disease and focal segmental glomerular sclerosis. And there was a lot of excitement that this might be the so-called circulating factor that we see in kidney disease. But it turned out on further testing and doing larger studies that it was more a marker of kidney function or decreased kidney function than a marker of FSGS per se. And so, like I said, most of these listed here have been shown to be beneficial in some studies, small human studies or animal studies. Many of them don't have a standardized method to assess them, so that impacts the reproducibility part that I mentioned about biomarkers. So they're still being assessed. So I would say for these markers to be continued, stay tuned. We'll see where this leads us. So there are genetic forms of steroid-resistant nephrotic syndrome. So this is a group where we can, if we test, assess whether there's a genetic component. The genetic forms of nephrotic syndrome, as you see, tend not to respond to corticosteroids. So there are debates in the pediatric nephrology community about whether when a child presents in that typical age range, whether we should go directly to steroid testing or do our usual treatment of corticosteroids to start with, and then if they don't respond, do the genetic testing. So there are mutations in the gene called NPHS1, which encodes for a protein called nephrin. NPHS2 encodes for a protein called podosin. And these are found in the podocyte, and I'm going to show you a picture of that a little bit later on. Then there's WT1, which encodes a transcription tumor suppressor protein and can be associated either with isolated steroid-resistant nephrotic syndrome or with some syndromes like Dennis-Drass syndrome that have nephrotic syndrome incorporated, but other things as well, and a risk for developing Wilms tumor, impact on urogenital development, et cetera. Then there's PLCE1, which some people refer to as NPHS3, which encodes phospholipase C epsilon. Then there's some less common mutations that cause steroid-resistant nephrotic syndrome that you may or may not have heard of. One is INF2, there's LAM2, SMARC, AL1, and TRPC6. So these are all gene mutations that have been identified that can result in nephrotic syndrome. I would like to emphasize that the likelihood of what we call a monogenic cause, meaning just one gene is impacted for steroid-resistant nephrotic syndrome, actually decreases with age. So it's highest in the first year of life. And so a lot of people feel if a child presents with nephrotic syndrome that early on, it probably makes sense to do the genetic testing first, as opposed to the kids in the 2 to say 12-year age range, where while one of these mutations is possible, they are more likely to have something that might respond to corticosteroids. So what about genetic testing panels? There are some commercially available panels that can be used, and you may have heard of these. There's Invitae, or Kidney Code, that tests for 195 genes that are associated with progressive kidney disease. And then there's Natera, or Renasight, that tests for 385 genes associated with chronic kidney disease. So neither one of these panels is isolated to just nephrotic syndrome. You can specify which genes you want to test for and look specifically for nephrotic syndrome genes, but just to make the point that they test for a wide variety of kidney disease beyond just nephrotic syndrome. They're relatively easy. You can use blood, saliva, or a buccal swab. And both of these companies provide genetic testing if your physician opts to go this route. genetic counseling, so that you know what the test means and what the test doesn't mean, and whether or not you need to test other people in the family. IgA nephropathy. So while this isn't the most common glomerular disease in children, it is certainly the most common glomerular disease worldwide. And it's a diagnosis that right now is made by a kidney biopsy. So what I'm showing you here is what's wrong. IgA is one of the antibodies that we produce to fight infection. It lines, usually it's most prominent in the nasal and respiratory passage and in the GI tract. And you can imagine that's where we take in most of the things that we're exposed to, and the IgA is there to help to protect us. But what's been found in the case of IgA nephropathy, here you have a normal IgA with the hinge region here. And galactose is usually part of that. The problem, as I'm sure you can see here, is that this is missing from this hinge region here. And therein lies the problem with IgA nephropathy. So you have that defect in what's called O-glycosylation, so that it's galactose deficient IgA. And so our bodies then look at that and go, that's foreign material, it's not normal. And so we form antibodies against that. So you can think of this as an autoimmune disease. The antibodies that are formed then bind to that abnormal IgA and deposits in the kidney. When we have what we call immune complexes deposited anywhere in the body, it sets up a whole inflammatory process. That's the signal to your white blood cells and everything else that, hey, here's a foreign invader, come and get it. So you can think of it as the kidney being injured kind of as an innocent bystander. These complexes are there and the whole process gets set up. The patients get hematuria or blood in their urine as well as proteinuria. So it's been found that in the majority of IgA nephropathy patients, you have elevated levels of this galactose deficient IgA. And you have elevated levels of the autoantibodies, and those have been shown to correlate with poor long-term outcome. The problem is there's no standardized test to do this. So we're back to, if you think of that list of the ideal biomarker, we're not quite hitting that with this. So with no standardized test, it makes it hard for it to be reproducible. Then the C3 glomerulopathy, pretty rare form. It's sometimes classified as a form of membranoproliferative glomerulonephritis. In this case, unlike IgA, there are no immune complexes deposited in the kidney, but there's a lot of C3. And C3 is one of the proteins that's part of what we call the complement cascade. And what you see in the blood of these patients is very low C3 levels, but that's really nonspecific. We see low C3 levels in lupus and other diseases. So the low C3 level in and of itself doesn't give us the answer. What is promising right now is that there are genetic and functional tests that you can do of this complement pathway to figure out what may be causing this. Is there a molecular cause underlying? But unfortunately, there are no validated prognostic or predictive biomarkers. Membranous nephropathy, uncommon in kids, but it is the most common cause of nephrotic syndrome in adults. And in this disease, what's been identified is what's called an M-type phospholipase A2 receptor. It's on the podocyte. And that receptor is targeted by antibodies. So the circulating antibodies actually have been found to be sensitive, specific, prognostic, and predictive of the outcome of membranous nephropathy. On kidney biopsy, the pathologist can also stain for these PLAR2 receptor antibodies. And this is the only validated biomarker to diagnose a specific glomerular disease. So it's the one piece of good news that we've had, I think, in the last decade in terms of a validated biomarker to diagnose disease. So I'm showing you this picture to give you, when I showed you the open capillary loops, the open capillary loops in the earlier picture. So this is magnifying this at the electron microscope level. So this is the capillary, there's blood flowing through it. And this is the podocyte. This is the reason I wanted to show this picture to you, because so much of what we talk about in glomerular disease has to do with the podocyte. So it's a cell that sits outside this capillary, and these are the foot processes. Then the spaces in between here are the filtration slit. This is where things go through and is allowed to filter everything that goes through. So some of the genetic mutations that I talked about, the nephrin, podosin, those are proteins that are along these filtration slits. And so when you get a defect in those, the slit allows more protein to go through into the urine rather than staying in the blood. This part is the mesangium. Here's another capillary loop and another capillary loop. What about newer approaches to biomarker development? We'll talk about proteomics for a minute. Proteomics are important because most diseases manifest at the level of protein level. You know, the genes that we talk about are giving our body the instructions for making specific proteins, and when things go awry, you can see problems with the protein. So proteomics is the large-scale study of different sets of proteins, either proteins produced by the entire body or by specific organs. And the term used for that is the proteome. You're probably familiar with the term the genome, which we know is the information about what's going on in our genes overall. This is the proteome, looking at the product of those. So you can look at proteins in the urine, for example, and compare steroid-sensitive nephrotic syndrome to steroid-resistant nephrotic syndrome. And often what will come up is a panel of potential biomarkers. So proteomics generally won't give you a single one. You're looking at a group of things that can be assessed. And they can give us some insight into disease mechanism, which is what we really want to know, because if we can figure out the mechanism, it gives better information for trying to figure out a treatment. So there is a lot of research ongoing looking at proteomics. People have been collecting urine and trying to see if there really are good patterns that are helpful. Then there's metabolomics. So you know that we metabolize our food, etc. And metabolomics is the study of these small molecules or metabolites in a biologic sample. So you can just look in cells, you can look in biofluids, meaning blood, urine, etc., or tissues. And the term for this is the metabolome. There are some small studies going on in glomerular diseases right now. And the thought is that analyzing blood or urine may be useful for identifying candidate biomarkers, but we're not quite there yet. Then there's transcriptomics. So that's looking at the tissue and cell-specific gene expression, looking at the RNA within a cell. So the RNA is like the blueprint that derives from, as your DNA, the RNA, the making the protein. There are actually some promising findings for FSGS, not quite yet ready for prime time, as they say, but very interesting data coming out. And there's ongoing NIH research. Some of the projects that the NIH has funded looking at this, the Kidney Precision Medicine Project. There's the Genitourinary Development Molecular Anatomy Project. There's Rebuilding a Kidney. And what I didn't list here are two projects that you may be familiar with, or two studies rather, Neptune and CureGN, both of which are funded by the NIH, who are also looking at this. So the hope is that at the end of all of this, we'll be able to really get down to some detailed ways of differentiating one type of glomerular disease from another. So what about kidney biopsies? This is, of course, what we generally use, and it's traditionally descriptive. It's often diagnostic, but it's not always diagnostic. And you can estimate prognosis, but again, it's not great. I mentioned earlier, if you've got a lot of scarring in some parts of the kidney, or you've got a lot of infiltration of cells, there are scoring systems. For example, with IgA nephropathy, there's the Oxford system, and there are a couple of other systems that say if you have this percent crescent or this percent interstitial inflammation, it's giving you some ideas about prognosis, but it's not absolute. And we think that if we can do the molecular testing of the biopsy tissue, it can provide some very useful mechanistic information. So if we can combine those omics that I just mentioned with the clinical and genetic information, maybe we can get to the point of optimal individualized treatments and not expose people to treatments that, if we know the mechanism, we know that a particular drug or biologic would not be effective. So I'm going to summarize that glomerular disease clinical presentation is very heterogeneous. The traditional biomarkers that we use are inadequate for precise outcome prediction and for guiding therapy. There are many candidate biomarkers out there for various glomerular diseases, but only one that's been validated, the PLA2R antibodies for membranous nephropathy. There are ongoing studies of newer approaches to biomarker discovery, and we hope that that will make the kidney biopsies more informative. And if we're lucky, perhaps make the kidney biopsy obsolete one day if we can really get the kind of information that we need from these biomarker approaches. So I will end there, and I'm happy to take questions. Thank you.
Wonderful. This was very interesting. Thank you, Dr. Moxey-Mims. This was great. I know we had some folks that were popping in between a couple different ones. If anybody does have a question, please put it in the Q&A or the chat. But I had some folks that, let me read you a question that came in. What are your thoughts on the importance of changing the child's diet to help control the rare kidney disease?
Yeah, there's been a lot of consideration of that. For the most part, it doesn't seem to make a lot of difference. I know there were some small studies out there looking at diet, but for the most part, it doesn't help. The one instant type of disease that you could consider like a dietary supplement, there's a specific type of glomerular disease that you can see where the child, the patient, is deficient in coenzyme Q, and so you can supplement with that, and that actually does seem to help in that specific case. But for most of the forms of nephrotic syndrome that we have, dietary changes don't seem to make a whole lot of difference.
Okay. I guess just in regular CKD, just watching your sodium, I guess, could only be beneficial.
Oh yeah, so certainly we tell patients when we have them on the high dose steroids, we do put them on a sodium restriction. So yes, if you're talking in that sense, yes, we put them on a sodium restriction because if they're taking in a lot of sodium, that's then exacerbated by the steroids, and then
Right.
hard to get rid of all that fluid, they continue to hold on to that.
Right. Good. Next question. What is the most important thing parents and a pediatric caregiver can do if they have a child that doesn't seem to be responding to, any of the standard treatments?
So if they're not responding and they have not yet had a kidney biopsy, the first thing they need to do is have a kidney biopsy to see what is it that they have that we're treating. And then there are a series of treatments that you can go through depending on what you find. So for example, if you have a child who may have been initially responding to steroids and then later on stop responding to steroids, or they're one of these frequent relapses or steroid dependent and you just have a hard time getting them off steroids, some of the things that we consider are rituximab, which is an IV infusion.
Right.
That can be helpful. If they're not on what we call an ACE inhibitor, an ARB, considering adding one of those. Those are blood pressure medicines, but they do have an effect on decreasing the amount of protein excretion. There are other treatments that we can consider. Tacrolimus is one that we use a little bit more now than we used to when we had more cyclosporin use. But there are a variety of drugs and different algorithms that you can consider for what the next thing to try in this patient would be. But I would say, if they've had corticosteroid and not responded, sometimes people will move on to one of the other drugs without biopsy. And I would say if they still don't respond, then that's definitely the time to do a biopsy to see what you're dealing with. And to also consider getting genetic testing to see if that helps you to figure out what you're dealing with.
Right. Yeah, there's been a lot of increased awareness on genetic testing, which has been wonderful. I guess the last question I have we got here was, when do you think we will see more clinical trials for children? There are so many, but relatively few for children. Why do you think that there are few trials for children, kids?
So, I mean, I'm hoping that we will be seeing more trials soon. We've, what the drug companies tend to do first, of course, is to do trials in adults first.
Right.
None of these diseases that I've described in this presentation are unique to children.
Right.
And so, of course, for the drug manufacturer, it's safer. It's less risky for them to start in adults and then expand to children. So we saw that, for example, in the duplex trial, the sparsentan, looking at that, they started in adults, but then they did move the age range down and started to include children.
Right.
And we're seeing that with other trials that are ongoing now, not just with glomerular disease, but in chronic kidney disease of other causes. Now that the requirement is being built in for you to do testing in children, but they tend to do their testing in adults first, get some of the basic data, do a lot of the safety profiling, and then move on to children. But so yes, currently there are fewer for children, but I think they're coming as the manufacturers get the data in adults and then start to look at kids. And just to emphasize that it's really important that we not just simply extrapolate and say, oh, well, that worked in adults, so we're going to try it in children. It's really important to do the trial properly and get the data to determine, does this work? And again, these biomarkers hopefully will help us to determine, are the pediatric versions of these diseases different on the molecular level from the adult version of these diseases, or are they actually exactly the same? And like I said, stay tuned.